Okay, welcome everybody to the second in our lecture series, Beyond the Basics. Today we want to talk about palliative care, and what I'd like to do for you today is to look at conventional medical care, palliative care, and hospice care, and kind of compare and contrast the three and talk about how all three work together. I get a lot of questions about word origins, and so palliative comes from the Latin pallium, and pallium means a mantle or a cloak, something that you wrap yourself in when the weather's inclement to give you comfort. And so that's the origin of the word palliative. Bringing this project to a hospital made me feel like Don Quixote, because the concept was that everything should be done for everybody under every circumstance, and talking about actually focusing on somebody's comfort was like Don Quixote jousting at a windmill. And so I have a lot of feelings about this art, because it sort of a few years ago was kind of how I felt every day. The best graphic for me to try to explain all three, conventional medical care, hospice care, and palliative care, is this little cartoon. And you sort of imagine that you're born over here. This is your lifeline. 90% of us are going to die of a chronic illness. So there's a point in our lives in which a life-limiting illness is diagnosed. Prior to that time, hopefully where all of us are, our treatment should be 100% conventional medical care. And conventional medical care is top-down, the way we were all taught. You make a diagnosis, you provide treatment that's disease-specific, and your goal is to cure. But the calculus begins to change when this life-limiting illness is diagnosed. Conventional medical care is still the bulk of the treatment, and this triangle represents the proportion of treatment that should be conventional medical care. But obviously, beyond this point in someone's life, they're not going to be able to be cured. So the goal has to change from cure to remission of disease. But also at this point, we begin to consider palliative care. And palliative care has an increasing role as the disease progresses. And palliative care is bottom up. Palliative care is, the focus is not on the diagnosis, but the focus is on the symptoms, and the goal is relief of suffering. And so the two work together like the yin and the yang. And as the disease progresses, the benefits of conventional life-prolonging therapy become less and less. The benefit of palliative care becomes more and more, and the proportions should change. Eventually, we reach a point where there is no further benefit at all from conventional medical care. Conventional medical care becomes futile. And at that point, the patient's treatment should be 100% palliative. And the definition of hospice care is when somebody's treatment is 100% palliative. Now, this cartoon is a little in error in that hospice care actually continues, as you all know, beyond death with our bereavement services. So all hospice patients' family, we don't treat just the patient, we treat the family, and for at least 13 months there should be bereavement services as part of hospice care as well. The problem, of course, is doctors, families, everybody puts the patient in the wrong place. You know, we're treating the patient as if they're over here someplace, when in fact they're over here someplace. We had a palliative care consult at the hospital last month, and a consulting physician wrote this flaming note how grossly inappropriate a palliative care consult was. This patient was absolutely not hospice appropriate. Patient died that evening. You know, so it's like the kiss of death when somebody says they're not ready for hospice. So it just shows that we all want to believe all of our patients are over here. So every patient, if we appropriately put them in the right place on their lifeline, then the treatment should flow logically from that. But unfortunately, we don't. Okay, well, let's look at the curative model of disease. Although it's appropriate most of the time, but look at some of its flaws. Only the disease matters. That's all we care about when we're trying to cure somebody. You're in a car accident, you're in multiple trauma, you're in the emergency room, you're going to have 3 operations. We know we're going to hurt you bad, but we don't care because we're going to cure you. So the disease is the only thing that matters. Suffering then becomes irrelevant because we know we're going to hurt you, we know you're going to suffer, but it's worth a lot of suffering if you can be cured. Unfortunately, the perception then, and this is something that myself and my colleagues are particularly guilty of, is if we're healers of the sick, and if one of our patients die, then that's the ultimate therapeutic failure, and we have to come, as physicians, come to terms with that. Well, the palliative model of disease looks at the problem somewhat differently. We recognize that illness, suffering, and death are inevitable consequences of life, that we have a moral obligation to try to relieve suffering, that special training and skills are required for that, and that palliative medicine, we're not here to compete with conventional medicine, we're here to complement it. The two should work together to maximize the care for the patient. Or let's take an example. And our multiple trauma, I think, is fine. But just to stay with the same theme, let's stay with the cancer theme and take a woman that has a very small breast cancer, less than a 1 centimeter breast cancer. We are expecting to cure her. She's over there someplace. Our goal is to eliminate the disease. We're in a win mindset. And obviously, if this patient should have an arrest during their treatment, then cardiopulmonary resuscitation is an appropriate treatment, and the patient is absolutely not hospice appropriate. So that's curative, and that's a patient prior to the diagnosis of life-limiting illness. Palliative active, staying with our story of the breast cancer lady, despite the fact she had a good prognosis, she recurred. She recurred in bone, and now she's over here someplace. Former Senator Edwards' wife is in that situation. If we put her on an anti-estrogen medication, she could get a remission that could last for many years. So still life-prolonging therapy is the bulwark of her treatment, but we need to address her symptoms, her pain as well. And we need to, and our tolerance for suffering from treatment-related complications starts to go down. Since we can't cure the patient, we don't want them to suffer unduly from the treatment. So treatment toxicity, we don't tolerate much of at this point. So here, our goal is to prolong life. Our goal, we're seeking to arrest the disease. We're still in a fight mode. CPR is probably appropriate, and the patient is not hospice appropriate. Palliative symptomatic. After our sticking with our same story, our same lady with breast cancer, now after a several-year remission with anti-estrogens, she has now relapsed again, and she's over here someplace. We can put her on chemotherapy. She might get another remission. It's not going to last as long as the last one. Chemotherapy drugs have toxicity, but still life-prolonging therapy is an important part of her treatment. Her symptoms are more problematic, and palliative care is going to play a greater role. Our goal is more focusing on comfort now. There still may be some response to tumor or her disease. Our mindset is beginning to change to a living with it concept. CPR may or may not be appropriate, and hospice may be something to consider. Now she has progressed on chemotherapy. It's unlikely she's going to get any further benefit from chemotherapy. Further life-prolonging therapy is of no benefit. It is futile, so she's over here someplace. Our goal now is completely comfort. We have no reasonable expectation for response to further anti-cancer treatment. We are in an acceptance mode. CPR is no longer appropriate, and this by definition is hospice. So hopefully these little snapshots give you a sense of how the three modalities, conventional medical care, palliative care, and hospice care, all work together. A lot of questions come up from patients and families about finances and money, and most of our patients are Medicare beneficiaries, and so we need to be reasonably facile with the Medicare hospice benefit. And to be eligible for the Medicare hospice benefit, the patient has to be a Medicare beneficiary. Both the attending physician and the hospice medical director have to certify that the patient has a prognosis of less than 6 months, quote, if the disease follows its usual course, unquote. And that's the language in the federal law. That doesn't mean our patients are you have to die within 6 months, and that's a major misconception from patients and families. We had a lung cancer patient last year who had massive intrathoracic tumor. There was just a little air in the apices of both of his lungs on chest x-ray. He had a superior vena cava syndrome with his big swollen head and arms. He lived 2 years. Why he lived 2 years, I don't know. But it's important to recognize that obviously we're not in charge of how long anybody lives. We are making an educated guess to that regard. The new conditions of participation, which are, as of December 2nd, we're all going to have to live by. They are looking for increasing documentation of this prognosis. And so in addition to both the attending physician and the medical director signing the certification form, the medical director or my designee also is entering a note into MISIS explaining why we feel this patient is appropriate for hospice. And both diagnosis and comorbidities and symptoms all can figure into that. If the patient has a pancreatic cancer, then that's probably all you need to say. If they've got debility and decline, well then I got to write more to show all the comorbidities and what we're justifying. Patient and families have to agree to a hospice care plan. If you're going to run around all over the country to various medical centers seeking treatment, that's not part of a hospice care plan. If you're going to go down to Tijuana to get coffee enemas, that's not a part of a hospice care plan. And so one reason not to be eligible, even if you've got all the right diagnoses, is if you don't accept our plan of care. We've talked about the palliative plan of care, the focus on comfort. Well, what do you get from being a Medicare hospice benefit? You get the best insurance there is. It covers everything related to your hospice diagnosis, as long as it's consistent with a hospice care plan. And as you know, there are 2 90-day certification periods and then an unlimited number of 60-day certification periods. So there are built-in checks to make sure the patient remains appropriate. And that's why at our team meetings, we discuss appropriateness for recertification of these patients. Patients may revoke at any time for any reason and go back on their regular Medicare. There is a nice little pamphlet, CMS 02154, which you can get a free copy of calling 1-800-MEDICARE. I am amazed this was published by the federal government. It is readable. It's very nice. The print is reasonable size. It's an excellent brochure for patients and families. Clearly no one from the IRS had anything to do writing it. I think that explains why you can understand it. Well, we define palliative care. Palliative care is quality medical treatment for people with life-limiting illnesses. The focus is on the patient. The patient defines their goals and we seek their goals. Some people may be more concerned about pain management, just as an example, regardless of whatever it takes. Some people may be more focused on interpersonal relationships and may want more pain and less sedation from medications. I had a fairly well-known author a few years ago who was a patient of mine, and he had a book that he wanted to finish. And he wanted very little pain medicine, and because he wanted to finish that book. So that was his goal. We guide patients and families to transition from curative to symptom management. This is probably the biggest piece of the puzzle. If you look at palliative care as kind of sitting in between conventional care and hospice care, making that transition, making people realize that your lab work and your PET scans sort of don't matter anymore. What matters is how you feel. And that transition is very difficult. And there is a perception that it is, the transition is difficult for unsophisticated patients and families. But we have had PhDs, we've had physicians' families recently who had every bit as much trouble as the people, as they say on the Eastern Shore, who are partially educated, which means they can't read. I don't know if you've experienced that, but when somebody on the Eastern Shore says they're partially educated, that means they're illiterate. So it really affects all walks of life. We want to address their needs in the context of their own social system. We see people from a lot of different cultures who have a lot of different needs, and they may be very different from what we've been used to, and if we don't have the resources in-house, we need to go out and get those resources. Example, we had a Native American family recently, and social work went out and got some resources and had them come in and talk to us at a team meeting and help us meet the particular needs from their culture. We want to strive to deal with all types of suffering, not just the physical. And this is where I constantly make a mistake, is I'm treating people's physical symptoms and I fail to recognize that the source of their symptoms are non-physical, but they're projecting them into physical symptoms. Our values is we value life, we value death as a natural process, and again, I think something that a lot of the public fails to recognize is that people sometimes have amazing personal growth from their dying process if we but allow them to do that, and we should facilitate that personal growth. And we need to recognize patients, families, all their needs, all their hopes, all their fears. We are not the gulag. We don't force ourselves on anybody. We can only provide care when patients and families are prepared to accept it. And I have been fired many times, but I've been amazed some of the times that I was summarily tossed out on the street. They heard what I had to say and they came back. And I think that's an experience probably all of us have had. So you never know, no matter how much negatives you get when you have a patient-family interaction, that they may have actually benefited from that and they may come back and seek our services. Again, the quality of life, we need to understand what the quality of life that's important for the individual. Caregivers, likewise, have to enter into this therapeutic relationship, and dignity and integrity are a very important part of all this. Whole communities benefit when we have this unified approach to suffering. Well, who is eligible for palliative care? Palliative care currently is a physician consult model at Peninsula Regional for inpatients. So the attending physician consults the palliative care team, and we do a consultation and follow-up visits as appropriate. We are currently developing an outpatient palliative care program, which is going to be starting in January. And anybody who has a life-limiting illness, and particularly if they are having uncontrolled symptoms, whether they be physical or non-physical, they are eligible for a palliative care consult. The bar is intentionally tried to be set low for who should benefit from a consult, but unfortunately there's a lot of perception that the bar is very high. So we probably don't begin to see as many people as we should. No particular prognosis is required, although typically we're seeing people in the last couple, 3 years of their lives. It could be any patient, any age, any diagnosis. Hospice care and palliative care are not cancer services. A patient that dies of dementia is just as dead as a patient that dies of cancer, but somehow that perception is still out there in the community. We do have a screening tool for the anal retentive types amongst the hospital staff that like little checklists, and you can come up with numbers and scores. After working with it for a while, most of the people that felt they needed those checklists have kind of thrown them away because it becomes pretty intuitive. Our palliative care team is transdisciplinary. We have a physician, nurse, social worker, chaplain, in collaboration with the primary physician and hospital staff. Often we'll have a care coordinator, the attending doctor in the hospital that'll all participate. What's the difference between multidisciplinary and transdisciplinary? Anybody know? There was this painting or photograph I saw recently that showed a highway that had just been striped, and there was like a dead possum in the center of the road that had been run over, and the county striped down the middle of the road right over the dead possum. And if you ever watch the guys with the striping trucks, there's always a guy sitting on the back of the truck with a shovel, and all I had to do was jump off the truck and shovel the possum off before they striped over him. But of course, what does he say? It's not my job. And so the difference between multidisciplinary and transdisciplinary is that those are words we're not allowed to use. We're not allowed to say it's not my job. So when a patient or family member wants to talk about spirituality with me, I can't run out of the room and get on the phone to call the chaplain, or has serious counseling needs that I'm not an expert in. And I complained to our social work department. I says, well, I don't know how to deal with these things. And they said to me, Dr. Dave, you just need to do two things. Whenever that happens, I want you to sit down, and I want you to shut up. And it's amazing how effective that is. Just listen. So I can do that, and then first break, then I get to the phone and go, help. But it's the same thing. And if the chaplain is seeing the patient and the patient wants to talk about their pain, you can't say, well, oh, can't talk about that, I need to call the doctor. Chaplain needs to listen and then report back. So we all have, so that's transdisciplinary. Again, we provide a consultation service to hospital patients. And we meet as a team. Actually, we have sort of an informal meeting every day to go over all the patients in the hospital. And once a week, we have a formal team meeting. Probably the biggest procedure that we do is the family meeting. And we coordinate with all the family members, and typically there's 6 kids, 5 of whom are perfectly rational and 1 is psychotic. And you got to get them all in the same room at the same time and help get everybody on the same page. And it's amazing how much therapy comes out of those meetings, but boy, they're devastating. I mean, once you've spent 2 hours in one of those, you're done for the day. But that's a very important part of what we do. There's a great review article on palliative care services and its benefits that was in the Journal of Palliative Medicine this year. And this is the Journal of the American Academy of Hospice and Palliative Medicine. So it's a well-respected medical journal and a good reference. This kind of sums up what a lot of people view as of palliative care. Since the doctor can't bring himself to tell the patient what's wrong with him, he says, well, I'll get somebody else that can. Meg Russo has not yet allowed herself to be photographed, but she should be over here. We have physicians, social workers, chaplains, nurses, a good transdisciplinary group. Well, what are the outcomes of palliative care? We relieve pain and distressing symptoms. We have honest and compassionate discussions of diagnosis, prognosis. It's amazing just being honest and straightforward. People really want that, and they hear all the nonverbals when we're doctors are often accused of being vague, and often we're vague is because we don't have all the answers. But if you do know the answer, tell the truth. Provide support for difficult decision making. And this is something that is often not appreciated, and particularly not appreciated by a lot of the specialty groups is that if they're going to benefit from conventional treatment, they should get it. And we want to be the advocate. If somebody's got hip pain and they need a course of radiation, you know, the palliative care team is not going to be there saying, oh, no, don't do that. And we said, no, it's a great idea. We need to do that. You know, 2/3 probability that you're going to have dramatic pain relief from that. We think you should do that. Now, there's a lot of inappropriate treatment that we need to talk people out of. But when the prescribed treatment is rational and consistent with a good care plan, the palliative team should be a big advocate of that. And a lot of published studies show that with palliative care consultation, the compliance with prescribed conventional treatment actually goes up considerably. Patients and families' satisfaction goes way up. And a lot of the reason it goes up is because we meet their goals. If you have lung cancer that's metastatic to your brain and your goal is to be cured, you're not going to meet that goal because you're going to die of your lung cancer. And so there's no way you're going to have satisfaction because you didn't meet your goal. But if your goal is, if we refocus the goal, reset the goal to pain relief, that's a goal we can achieve, and satisfaction goes up when you set reasonable goals. Palliative care services result in significant increased referrals to other and appropriate care settings, whether it be hospice or nursing facilities. And we'll talk a little bit more about costs in a couple minutes. Palliative care controls healthcare costs as well, which is why the federal government's interested in all this. And this is the fiscal imperative. We are dealing with an explosion of healthcare costs, and estimates are about 1/3 of healthcare costs now are provided, are inappropriate and futile. So we are spending a lot of healthcare dollars on treatments that are of marginal benefit or don't work at all. And appropriate palliative care and hospice care can, in addition, help deal with this explosion of healthcare costs. And if the last month hasn't taught us anything, it's taught us that the United States is not a horn of plenty. Now, a horn of plenty is full of food, and you can take all the food out of it you want, then it stays full. Well, you know, we only have a finite number of healthcare dollars, and we have to spend them wisely. And that's something that our healthcare system is having trouble learning about. Yes, ma'am.
Yeah, what happened in 95?
Everybody asks that question. I don't think that's a significant blip. And it may be that that's about the time that these managed cares agencies came in. Managed care translates as care denying. So, I mean, your cost goes down if you don't treat anybody. But if you drew averaged all these out, it may not be that much different. There's a lot of published data about palliative care programs at hospitals, and as those programs mature, cost savings for hospitals. And these are 1,000-bed academic medical centers, and you can see consults per year. We're doing 200 and some consults a year, I think. So we're probably in here, in between, down in here someplace. So there is significant potential for cost avoidance, cost savings by hospitals. And most mature palliative care services show excellent financial outcomes for hospitals. They also show financial losses for hospices, and that's why for these programs to work, they have to work as a joint venture between the two institutions, and the hospitals have to pay the hospices. And in fact, we have a cooperative services agreement with Peninsula Regional, and they provide some financial backing. We still take a little bit of a loss, but probably make that up with increased referrals. The money isn't why we have a palliative care service, but it's what you got to do to get grow and sustain one. It's because the bean counters, have to be appeased. Recent article last month in the Archives of Internal Medicine looked at 8 very different hospitals with mature palliative care services and average daily savings after palliative care consultation of between $280 to $375, representing thousands of dollars of cost savings for the hospitals per admission, with reductions in pharmacy, laboratory, intensive care costs. Peninsula Regional is right around 400 beds, so you can figure $1.5 million or so annual savings we're probably representing to them with this program. A little bit of our demographics. This is a couple years ago. 3-month period, we had 73 consultations, about 50-50 male, female. 1/4 of the patients were under age 60. Palliative diagnoses are different from the type of diagnoses that you think of. The patient may have lung cancer, but that's not their palliative diagnosis. Palliative diagnosis may be pain or dyspnea or what have you. And so you get a snapshot. We keep track of a lot of metrics from the day of consultation till the last day they were in the hospital. Substantial reductions in pain, in dyspnea, in agitation. So how does the hospital benefit? And we've talked a little bit about this. Maryland hospitals have this complex system for reimbursement. We're, I believe, the only state that's not a DRG state. And they get rewarded financially for having a short length of stay. They get penalized for if they have too many proportional deaths in the hospital, and so we can reduce their mortality rate by moving the patients out of the hospital into hospice care. Where did that come from? I don't know. The hospital makes their money on short stay, high technology patient. Somebody comes in for a lot of complex cardiology, catheterization, electrophysiologic studies and what have you. And Peninsula Regional maintains pretty much a full census all the time. They're very, very busy. So that if we can move the patient out of the hospital into hospice care, that opens up a bed that they can get one of their patients that's going to be more profitable for them. We have a blended staff of the palliative team, some hospice employees, some hospital employees, and so our staff costs are shared. We provide additional expertise, and we provide prestige for the hospital. The hospital administrators, when they go to their annual meetings, they've been saying that quality hospitals have palliative care services, and they all march to the same drummer. And if you notice in the advertising for the hospital, palliative care is always listed in their publications and their ads in the paper now. And as we talked about, what really motivates them is we save them money. Well, how does coastal hospice benefit? Well, it increases our number of referrals, particularly our number of referrals to inpatient hospice, but we also have an increased number of home hospice referrals. Some of those patients we would have gotten anyway, but there's certainly significant numbers that we would not have captured and can benefit from our services. And if we get them upstream further, good data shows that patients that are referred within the last 7 days of their life probably don't get significant benefit from hospice care. So the earlier we get them, the more they're going to benefit. And because of the way Medicare reimburses us on a daily capitation, it also improves our revenue. So, and that's what we're talking about. We're increasing our length of stay by capturing these patients earlier on in their disease. And that means more dollars for hospice. Our inpatient admissions go up. Having physician in the hospital makes hospice and coastal hospice more visible to the community. And it's also a mark of prestige for a hospice to have a palliative care program. Well, these are all fine and good, but what really matters and what we're really in all this for is to serve the community. And so the real question is, how does the community benefit from having a palliative care program? We reduce the amount of futile care and the suffering that goes with that. By attention to physical and non-physical suffering, we reduce patient suffering. We increase both patient and family satisfaction, both by relieving suffering and by refocusing goals that are reasonable. We increase physician and staff satisfaction. You know, a lot of physician counseling, you know, I sit down with a lot of my colleagues, you know, it's okay for your metastatic cancer patient, it's okay for them to die. And obviously it's the right thing to do. Well, what's the doctor's role in all this? I sort of view physician as needs to go first, but probably is not the most important member of the team. And so the job for the physician mainly is upfront to get the physical symptoms controlled as quickly as we can, because all the other work that all the other disciplines do aren't going to be effective if the physical symptoms, whether it be pain or nausea or dyspnea or whatever, if those are huge, then they can't get past those. If we can get them comfortable and get their physical symptoms under control, and need to do that rapidly. We need to recognize that there are non-physical causes of suffering, and we talked about this a little bit earlier. People project their non-physical suffering into physical symptoms. We had a woman last year at our inpatient facility who was dying of cancer. Her ex-husband was a scoundrel and had been running around on her. They had a wonderful son who was a young adult, who was a well-respected police officer, and she was just having increased amount of pain, and I just kept dumping the narcotics in on her. And the real problem was that her scumbag ex-husband was going to get to see her son prosper and get married and have a family, and she wasn't going to get to do any of those things, and she couldn't tell us those things, and so she just said, you know, my back hurts. Until finally, you know, the counseling staff sort of kicked me in the backside and did some serious counseling with her and finally brought that out. And as soon as those problems got addressed, her narcotic requirement went way down and her physical symptoms were relieved. Need to be a team player, and this is a big problem for docs because we're all in this sort of a military hierarchy. Doctor gives the orders, the nurse says aye aye and does what she's told, and we're not used to being team members. But you know, it's the reason I don't wear a tie and a white coat anymore. I do have a tie, but I usually keep it on the shelf. And to say we're all equals and sit around as a team member. And it's interesting, often the seemingly least important team member, or the person that sees themselves as least important, often is the one that really has the key to the problem. I've been amazed how often the hospice aide, who in the past has been sort of discouraged not to speak, will often say, no, that's not the case, this is the case. And then all of a sudden everybody realized that, yep, she was right. So we all need to be part of the team, and we need to support the patient's search for meaning. I'm astounded too how often patients and families put their doctor on a pedestal, and they really think that we have have this search for meaning, and they think we're going to solve it for them. But we need to understand that we don't have ultimate answers. I had one lady I made a home visit for, and a couple weeks before she died, she said to me, what's it going to be like on the other side? And what was astonishing is that she said it like she was convinced I knew the answer. So we need to help them search for meaning, but we need to understand that, you know, we don't have the answer to everything. And with this little cartoon from the New Yorker, And if you've ever come up from the subway, there's the "You Are Here" sign, and so it says birth here and death here, and just so you all know, this is where you are. Questions? All right, thank you all very much.